The title of this animated video is The Clinical Significance of Embrasure Space Anatomy. Now, there are two types of embrasure space. There's a gingival embrasure space, but also there's an incisal embrasure space that we will talk about as well. This is a very interesting image. This is taken from a textbook that was printed approximately 100 years ago. And it's basically correct with a few slight modifications. They realized back then that the length of an unworn central incisor was approximately 11 millimeters. But we now know if we want to have a very pleasing emergence profile, yes, it's 11 millimeters on the distal, but it's only 10.5 on the mesial. And this has a much more aesthetic presentation. What is interesting, if you ask most people which is the longer tooth, a central or a canine, everyone would say the canine. But in reality, the canine and the unworn central incisor and unworn canine are both 11 millimeters long. So if we draw a line from the gingival margin of the central incisor to the gingival margin of the canine, you will note that they're exactly on the same plane. And interestingly enough, if you draw a line from the incisal edge of the central to the canine, that is on the same plane as well. So therefore, a canine is 11 millimeters long as well. But let's look at the lateral incisor. First of all, the lateral incisor gingival margin is 1 millimeter incisal to the gingival margin of the central and the canine, and also this is misdrawn down here, but it is 1 millimeter short of the plane between the incisal edge of the central and the canine. So therefore, a lateral incisor should be 9 millimeters long. And if you will look, the premolars and the mesial buccal cusp of the first molar are 9 millimeters long as well. So it's very easy to remember 9/11 based on the tragedy this country experienced. Now think about the first molar. The first molar, the mesial buccal cusp, is part of the aesthetic presentation. But the tooth is torqued so that the second molar is over the ridge, and therefore the distal buccal cusp of the first molar is not part of the aesthetic triangle. Here we see the gingival embrasure space, and here we see the incisal embrasure space. And you will notice that the embrasure space, the incisal embrasure space between the central incisors is shallower and narrower than the embrasure space between the central and the lateral, and is even wider and more apical between the lateral and the canine. Therefore, the contact points similarly move apical because of the contours of those teeth. Now, we know that Tarnow has told us from the crest of the bone to the tip of the papilla in the normal situation is 5 millimeters. Therefore, you show no dark triangle, or you show nothing between the lateral and the central and a lateral and a canine. But if you will note here on the central incisor, because the contact point is so far incisal, typically there is a little, what I call an aesthetic enhancer between the central incisors. And if that is obliterated with a restoration, it gives an abnormal anatomy to the central incisors and is very aesthetic and gives them with crowns that I refer to as having a prosthetic look. Now let's look at an actual case, and you will see the pre-op on the left where we did crown lengthening and the post-op crown lengthening on the right. So let's look at the right slide. Notice that the embrasure space, gingival embrasure space between the central incisors, there is that little slight aesthetic enhancer that I mentioned. And if that's obliterated, then you have, as I call it, the prosthetic look, which is unaesthetic. The central incisors are 11 millimeters long on the distal, and 10.5 on the mesial to give the emergence profile that we talked about earlier. If you look at the gingival margin of the central incisor and draw a line to the canine, you will see that the lateral incisor, the gingival margin is 1 millimeter incisal to that. You'll notice that the lateral incisor is 1 millimeter off the plane. And if you notice, this is on a young patient with no wear, and the line drawn between the incisal edge of the central and the canine, it will be parallel to that apical line, which means that the central incisor and the canine basically are going to be 11 millimeters long. And if you look on the pre-op and on the buccal corridor and the post-op, where we have the teeth that are 9 millimeters long, and you need to have depth of smile on that. Notice that the embrasure space between the central incisor, this is a female, and typically you have a well-defined incisal embrasure space on a female. Often that is almost obliterated on the male, and you will notice as it moves distally that incisal embrasure space moves apically and gets wider, which means the contact point is going to remove apical. So here we see clinically what we've talked about on the other slide, and you will notice that we have a nice aesthetic presentation. Let's talk about the clinical impact of overly contoured crowns, especially in the embrasure space or the interdental area. Here we see a case, and we can see the swollen red tissue and the obvious periodontal disease created by these over-contoured crowns. Once we reflect the flap, then we see what the dimensions should be, because vertically from the crest of the bone to the contact point is going to be 5 millimeters, and at the level of the bone that dimension should be 3 millimeters. So in a two-dimensional view, the dimension of the papilla is 5 by 3 or 15 in the maxillary arch. But now we see where the papilla is going to be, and we can see how that there is excessive restorative material in the interdental area, and we need to create a concavity in that area using a fine diamond that we'll show you in a minute. Now we're talking about the interdental component, and we're going to talk about it in a three-dimensional view. Now we're talking about at the crest of the bone horizontally, that dimension should be 3 millimeters in the maxillary arch, and the papilla is going to come down 5 millimeters, and arbitrarily the distance in a buccolingual dimension in the maxillary arch is probably about 2 millimeters, so the total volume of the papilla should be 30 cubic millimeters. Now in the mandibular arch, horizontally, that distance often when we have crowding is much less than 3, so arbitrarily we're going to say 1.5. But again, the papilla is going to come up in that situation 5 millimeters from the crest of the bone vertically, and the distance from buccal to lingual is less than it is in the maxillary arch, so arbitrarily we're going to say 1.5. So therefore, the volume of the papilla in the mandibular arch is vastly smaller than it is in the maxillary arch, and we're going to say it's about 12 cubic millimeters compared with 30 cubic millimeters in the maxillary arch. So here we have reflected the flap, and we see where the papilla is going to come down to 5 millimeters. And we're going to go in there, as we showed you earlier, and apical to that periodontal probe, because where the periodontal probe is where the papilla is going to come down 5 millimeters. And we're going to go in there using a fine diamond, and we're going to remove that excessive crown material in the interdental area. And we're going to use a fine diamond to do that. And here we can see how we are contouring that, and you will note the concavity that has been formed, and that is going to allow the 30 cubic millimeters of volume to fill that area. So here we see the pre-op before the contouring was done and afterwards. And as we look at that, again, we see that contour point now not only in the mesial of the canine, but the distal of the lateral, the mesial of the lateral, and the distal of the canine, and so forth. And this is where the papilla is we're going to come back down to. And let's look at this diagrammatically. Here you can see my hands are opposite, and too often crowns are contoured in that fashion. But what we want to do, and of course this is an exaggeration, this is the concavity that we want to create, but it should not obviously be that involved. Therefore, when the crown is placed and it has that concavity, then the papilla can expand into that, and that is what I refer to as the Pillsbury Doughboy look. Some of you that are a little older remember this advertisement by the Pillsbury Company. We can see here that again the concavity, and we can see now the papilla can come down 5 millimeters and we can get a healthy situation. The same thing is going to be true on the central incisors. Notice where we come down 5 millimeters, but the excessive crown material in the interdental area. So this is pre-suturing, and this is post-suturing on that, and we're going to see here the pre-op view and the post-op or post-surgery view, and you can see how we have exposed those teeth, and that papilla is going to come down 5 millimeters and fill that embrasure space. Here it is sutured, and here it is 3 weeks post-op healing, and you can see how nicely that tissue has folded in, and that papilla between the central incisors is going to come down 5 millimeters on final healing. So this is the way it looks sutured, and this is the way it looks 3 weeks later, and you can see we do have that little aesthetic enhancer between the central incisors that really defines those central incisors. And this is our pre-op view and our 3-week post-op view, and we can see that we do have a healthy situation. Yes, ideally, we would like to have highly polished margins up there, but in a clinical situation where crowns have been done, the patient is paid a fee of $1,000 or more for each of the crowns. Simply contouring them may help make the referring dentist look better, and certainly is not a wrong compromise to make. But we've talked about the impact of the distance between the contact points on the central incisor in the classic article by Tarnow. Now, this is very important. When the crest of the bone is 5 millimeters or less from the contact point, the papilla fills the embrasure space 98% of the time. This is what Tarnow found. However, this is only true if the distance between the adjacent teeth is 3 millimeters or less. And let's talk a little further about that. For every millimeter, the horizontal distance is greater than 3 millimeters. The tip of the papilla will only come down 1 millimeter apical. So, if the distance is 4 millimeters across rather than 3, the papilla will only come down 4 millimeters. If the distance between the two adjacent teeth is 5 millimeters, the papilla will only come down 3 millimeters. And if the distance is 6 millimeters or greater, then you will have no papilla. So let's look at this case on a 16-year-old girl where we're going to go in there and actually remove the papilla. And you can see on the right where the crest of the bone is 5 millimeters from the contact point. The distance between the two teeth at the bone level is 3 millimeters or less. And Tarnow says, and we found out he was correct, that this papilla will come back completely. And here we see the black triangle that we created the day of surgery. And here we see a 3-week post-op, and as Tarnow has told us, the papilla has come down completely. And the reason being on that is that the distance between the adjacent teeth is 3 millimeters or less, so therefore the papilla will come down 5 millimeters. And because this is between a central and a lateral with a contact point in the middle third, that papilla will completely fill the embrasure space. So here's the pre-treatment view of this young lady, and the post-treatment view after we have finished the case, and you will see that the papilla has completely come down on that lateral incisor. So let's review about embrasure space in a three-dimensional view. What we're saying, the distance between the two teeth ideally should be 3 millimeters. And from the crest of the bone should be, the papilla is going to come down 5 millimeters on that. And we're going to guesstimate that the distance from the buccal lingual dimension is 2 millimeters. So therefore, there are 30 cubic millimeters of embrasure space. And it has the Pillsbury-Doughboy impact that it fits into the concavity on the distal of the canine, for instance, and the lateral incisor. However, in the mandibular arch, the horizontal distance is generally quite less, and let's say 1.5 millimeters, but the 5 millimeter vertical rule applies. And in a buccal lingual, I don't think that is as much as it is in the maxillary arch, and we're going to guesstimate that at 1.5. So the papilla space in the mandibular arch is markedly different in the maxillary arch, only a little over 11 cubic millimeters. And with teeth overlapping, that dimension should be less. So hopefully we have given you a good overview of embrasure anatomy, how crowns should be contoured so you get the most aesthetic impact on that, and hopefully this will help you in correcting cases where oversized crowns have been done and help avoid having the crowns completely redone.